Now we start with. I am welcoming every participant who are gathered here to listen Fatima Crispi madam, who is the teachers of the teacher, who have shared her knowledge for many students all together throughout all over the world. Actually, I should tell she has got a tremendous dedications towards this scientific progress in the maternal healthcare, especially in the fetal cardiac healthcare. So we are blessed to have her in our podium today for the all kinds of chapters right now. Today, she is actually addressing two important chapters in fetal hemodynamics. One is fetal arrhythmia, where we are actually studying the electrophysiology of the heart and we are understanding the beneath of the heart actually. The rhythm is the most important function of the heart to predict many kinds of things. And the most interrelated chapter is another in hemodynamics of the heart, fetal heart, that is the intrauterine growth restriction. So these both chapters are interrelated and we are blessed to listen from Fatima Crispi madam today, and she is the all alone have got a lots of research regarding all these things. We are going to listen from her. And today's this webinar has been conducted by triple effort of Tamil Nadu Trichy Fetal Medicine Sciences Institute by Dr. Malati, and by Vida Fetal Medicine Institute by Dr. Dilipan, and by Fetomania Foundation for Fetomaternal Healthcare. So these three foundation have tried for this kind of webinar. So today I welcome Dr. Malati to speak on this, the CV for the Fatima madam. Ma'am, please can.
Yeah, it's my pleasure to introduce a very esteemed faculty of coming from Barcelona. It's really a privilege to have you here, Professor Fatima. Fatima Crispi is a physician in maternal fetal medicine at BC Natal Hospitals. She's Associate Professor in the University of Barcelona and member of the board of ISUOG. She has been recognized clinical expert in fetal cardiac imaging and physiology with a unique clinic on fetal cardiac incorporating new imaging tools for assessing and enabling follow-up of fetal growth restriction. She leads a research line on fetal cardiac programming that is produced, and she's done a lot of work on almost close to 250 research papers demonstrating the vital importance of fetal heart adaptation to placental tissue preeclampsia, assisted reproductive technologies, and other conditions. Her work has also led to the evidence of long-term consequences of fetal growth restriction on cardiovascular health. So with a short introduction, the dais is yours, Professor Fatima Crispi. Over to you. Thank you.
Good afternoon or good evening, and thank you for the kind invitation. It's really a pleasure to be here joining this webinar, and thank you, Dilepan, for inviting me and for insisting me to organize this. And well, I think it's better that if we start. Let me try to start sharing.
Start screen.
Yes. Okay. Yeah, so the plan is to first talk briefly about fetal arrhythmias. I know that it's a tough topic, and Dilepan was telling me maybe it's too complicated, but I try to give just easy tips to better understand how we can manage and diagnose arrhythmias. Then we will do like a brief stop and questions, and then we will talk about IUGR. So let's start to the fetal arrhythmias. And well, I know that this is pretty difficult and sometimes people get overwhelmed with the arrhythmias thing. However, actually, with very easy tips, we can at least manage or start managing arrhythmias and then knowing how to deal or the first diagnosis and the management of that. So if we talk about arrhythmias, we know that we can have extrasystoles when we have an irregular rhythm. That means that instead of going in a regular manner, we have beats wherever, so it's irregular. So in most of these cases, that will be extrasystoles. Then we have the tachycardia, that is when the heart rate goes above 160. Here it complicates a little bit more because we have several types of arrhythmia, of tachycardias, but you will see that with easy tips, we will be able to manage that also. And then when the heart rate goes below 120, we will talk about bradycardias, that we have also several types. Okay, so this looks pretty complex with lots of things to do, but let's see how when we have in front of us a fetus that we suspect that the rhythm is not normal, that can have an arrhythmia, what to do first. And for that, we can, when we have a fetus that we suspect an arrhythmia, there are several techniques that we could apply. That's echocardiography, or we could try to get the ECG, that it's not really something that we can do right now, or the magnetocardiotomogram or the CTG. However, fetal echocardiography or fetal ultrasound, it's the one that will give us the most of the information and will be very, very helpful for that. And what we should do. So actually, to assess fetal arrhythmias, I always tell my fellows that the first thing to do is to do an umbilical artery Doppler. That's the easiest way to really check the rhythm of the fetus, and it's easy, reliable, and all of us know how to do it. So the umbilical artery will reflect the ventricular beats, so how the ventricle is contracting. So you see here in the picture that we have, if we check the umbilical artery and we see that the rhythm is constant, regular, and then it's the heart rate, it's between 120 or 160, we will know that this is normal, normal rhythm. If we have extra systoles that the rhythm is irregular, we will see it, because we will see in the picture here in the top right that we have some beats that look regular, but once in a while we have some beats that are not looking regular. And the same with tachycardia and bradycardia. So just by doing an umbilical artery Doppler, we are going to put already a name to what happens to the fetus. It might be normal rhythm, or extra systoles, or tachycardia, or bradycardia. So just with the umbilical artery Doppler, we can do this first step and put this first name to the arrhythmia that the baby has. But of course, that's just the beginning, yeah? Because if we remember from the physiology how the rhythm is constructed in the heart, we know that the rhythm starts in the atria, where the contraction is created, and then this contraction will navigate through the atria to the AV node. There it will stop for a while to concentrate all the rhythm coming from the atria, and then after a while it goes through the ventricles. So then, and when we do an ECG, we will have this P wave that reflects the atrial contraction, and the R wave that will reflect the ventricular contraction. With or in the fetal life, we cannot do ECG, but we can measure things with the Doppler that can reflect the atrial contraction and the ventricular contraction. Because in order to know the arrhythmias, we will need to know what's going on in the atria and what's going on in the ventricle, and to integrate that information, so to see at the same time with the same image what's the contraction in the atria and the ventricle and the relation between them. How can we do that? So one relatively easy way to do that is with Doppler, looking at the 4-5 chamber view. So if you see here the video, we see a heart that it's like a 5-chamber view, because we have the right and left ventricle, right and left atria, and the aorta flow. So in this, you see that at the same time we are seeing some red, that is the blood flow coming from the atria to the ventricles, and some blue flow, that is the flow from the ventricle going out to the heart. Then, if we put our probe of the Doppler here, sorry, in the 4-chamber view, sorry. Okay, if we put the Doppler sample here, we can at the same time something fall down here at my home. Sorry, that's okay. So we can have at the same time the blood flow coming into the ventricle and the blood flow coming out to the ventricle. So we can get in red, you see some blood flow going in. That's the diastolic flow coming from the atria to the ventricle, and at the same time, some blood flow going out from the ventricle. So this red blood flow, that's the EA waves going into the ventricle, that means it's reflecting the atrial contraction, no? So you know that when the blood flow goes into the ventricle, the mitral valves open, then there is first some blood flow going in early diastole, and then the atria contracts and put more blood flow into the ventricle. So in red, we are seeing 2 waves. The first is the passive entrance, is the early diastole, and the second one is the atrial contraction. And then we have in systole, the blood flow going from the aorta, that's the ventricle contraction. So we can have at the same time the atrial contraction and the ventricle contraction. So you can see that in the same line, just putting the caliper within the cross of the heart, trying to get this blood flow in and out, we can get both at the same time. And actually, on the tip that I can tell you, just to put in the cross of the heart and open a little bit the sample size to 4 or 5, something like this, so we can get these blood flows at the same time. And then it's easy because we will send one that is biphasic, that's the atrial contraction, and one that is monophasic, that's the ventricular contraction, and we can see the relation between them. Actually, we can do that getting the mitral and the aortic flow at the same time. We could also do it trying to get the pulmonary artery and vein at the same time. That's also relatively easy. We just need to get to the 4-chamber view. Do you know when you are trying to check the veins going into the atria? So at this point, when you load down the Doppler, and you see how the veins are going down, you can put the Doppler of the caliper of the Doppler there, and then open it a little bit, and just very easily, you will get like the pulmonary artery flow, that is this one that has this very high peak, that's the vein, that reflects the ventricular contraction, but the pulmonary artery. And in below, we are going to get the vein, the pulmonary vein that looks like a ductus venosus, but smaller, and it has this, it also reflects the atrial contraction. So by putting the Doppler caliper near where the vein is entering to the heart, we are going to get the pulmonary artery and vein at the same time also. And then in a sagittal view, we can also try to get the aorta and superior vena cava at the same time. This is more difficult, but if you train on it, actually it's also relatively easy to get. And in this type of views, we also open the gate and we can get, you see, and the superior vena cava that reflects the atrial contraction and the aorta that reflects the ventricular contraction. You don't need to do all this. You just need to choose one that you feel more comfortable with and that you can work with. And then just with any of them, you can get similar information. It's just that you can try to get it or try to train yourselves in any of these with normal fetuses and see what you think is easier for you. As I'm saying, there are 3 different places in the fetus that we can get at the same time the atrial contraction and the ventricular contraction, that you will see that later it's very, very easy to then use it to understand what's going on with arrhythmias. Okay, so with this mitral aorta or pulmonary artery vein aorta superior vena cava, as I was saying, we are getting at the same time the atrial and ventricular contraction. So we can see the relation between them. So how many atrias? So the normal heart has 1 atrial contraction and next 1 ventricular contraction, then 1 atrial contraction, next 1 ventricular contraction. And then we can measure the interval from the atrial contraction to the ventricular, that it's called AV interval, that it's actually very, very correlated with the PR interval in the ECG. And the normal thing is that the AV interval is shorter than the VA interval, so you measure the time from the atrial contraction to the ventricle, as shown here, and you can see that the normal thing is that from A to B is shorter than from B to A. Yeah, that's like measuring the PR interval. Okay. And another way of looking at this AV relation, apart from Doppler, is to use the M mode. Yeah, that's an alternative that we use. And as I was saying, you don't need to measure all these things, but you will see that knowing or Doppler or M mode and having skills on one of them will be very, very helpful to manage arrhythmias. I also know that M mode, usually it's not very commonly used, but actually if you understand how it works, it can be very easily and very helpful. So what's M mode? Okay, we are mostly used to have the 2D image, so to use in 2D. In 2D image is the image that we have here in the back, so that means that it has 2 dimensions. So we are seeing images in this direction and also in this direction. However, the first ultrasound machines were just giving us one dimension, yeah? And actually the ultrasound keeps this potential to give us information in only one dimension. What means one dimension? So we draw this line in case we draw with the M-mode line, that in this case is this yellow line. And that means that the ultrasound machine is just going to show us what this line is slicing, what is cutting, yeah? So if we just need to look at the line in the 2D image and then understand what's going on in the down image, yeah, in the spectrum. Yeah, so if we think about this yellow line, we see that first it goes and it slices some lung. So we will have some lung here that, well, for us, it's not interesting now. Then it's slicing the thickness or the myocardium of the right ventricle. So we will have here the right ventricle. Then the right ventricular cavity, that is this black thing. So down we will have the right ventricular cavity, then it's crossing the septum and then the atria, yeah? So the septum and then the atria and then the atrial wall. So if you see here, the down image is going to show us in the upper part the myocardium of the right ventricle, so the myocardial contraction, and down the wall of the left atria. So we are seeing again in this part, up in the upper part, the myocardium, so the ventricular contraction, and the down part, we are slicing the atria. To do that, you just need to tilt the heart like 45 degrees, whatever impression, but slice it at the same time, the ventricle and the atria. So then we can see both. So now I will run the video and we will show what's going on here with the time. Yeah, because the M mode slices the heart and show us with the time. And you see here down that there are some atrial contractions in yellow, and the upper part, we have the ventricular contractions that are these just small moving here. So you see that at the same time, we can have the atrial contraction and the ventricular contraction, yeah? So then, let's see if okay. In this image, stop image, I'm showing you that we have the beginning of the atrial contraction, then the beginning of the ventricular contraction, atrial contraction, ventricular contraction, 1 to 1. And then we can also measure this AB interval. Again, this is another alternative. So I have explained you 4 ways to look at the relation between the atria and the ventricle. 3 ways using Doppler, that would be the mitral and the aorta, the pulmonary artery and vein, and the superior vena cava and the aorta. And the other alternative is to use M-mode, slicing the ventricle and the atria. Okay, let's put that in practice and let's see some example of some arrhythmias and see how we can manage them using these tips I have been explaining you. First, I will show you a case of atrial extrasystole. So you can see in the video that it was a heart, a fetus, that we were checking it, and it was like quite regular, but once in a while we were seeing some extra beats. That's exactly what happens in atrial extrasystoles, that we have a normal conduction system, but there is a part of the atria that it's irritative or not well developed yet that creates once in a while some extra beats. We know that's a benign arrhythmia, and most likely when the fetus will mature, these extrasystoles will be reduced. But in any case, they are quite common and we are going to see them. So what happens when we have this extra beat? Yes, so we have our normal conduction system, but once in a while there is this extra beat. So if this extra beat happens late in systole, this extra beat will be able to be transmitted. So we will have an advanced ventricular beat. Yeah. So that's what happens, and I'm showing you here how can we measure that in Doppler or in M mode. So in Doppler, this is a superior vena cava aorta image, and we see the atrial contraction and ventricular contraction. Atrial contraction, ventricular contraction. Early atrial contraction, and then a ventricular contraction that is smaller, yeah, because it happened too early, but it transmitted. Then we have a compensatory pause, and then again, atrial contraction, ventricular contraction. And we can see the same with M mode below, that we have an atrial contraction that has gone too early, it's too advanced, but it has been transmitted to a ventricular contraction. But in the same fetus, in the same extrasystoles, it can also happen that this extra beat that is generated by the atria, it's happening too early and then it's not transmitted. Yeah, so instead of having an early ventricular contraction, we will have a pause, a missing ventricular beat. And that's what we can see here. Yeah, so we have atria contraction, ventricle, atria, ventricle, and then you see this early atrial contraction that is happening so early that it's not transmitted to the ventricle. So we have this missing beat here, and then we come back. So you have seen here that, of course, in the 2D, we can have an idea. With the umbilical artery, we can see that it's an irregular, but then using Doppler or a mode, we can see the relation between the atria and the ventricle, and we are seeing what's going on here, that sometimes we have an early on an atrial beat that happens when it should not happen, and sometimes we have an early ventricular beat or a pause. And that's very, very typical from extrasystoles. Yeah, that we, in order to be sure that they are extrasystoles, we need to use or Doppler or a mode to see the atria and the ventricle at the same time. Let's see another example. That's a supraventricular tachycardia. You see in this baby in the clip that at the beginning the heart was going more or less okay, but suddenly it starts going very, 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 very fast. If we look at the umbilical artery image, you see that at the beginning at the umbilical was okay, but suddenly it goes very, very fast. Typical, this is a supraventricular tachycardia, that it's a heartbeat that goes into the M mode and goes back to the atria. So it enters to a vicious cycle that it goes faster, 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 because from the ventricle it goes to the atria and it's generating this very fast heartbeat. Typical, the heart rate is very, very high, above 200. And typically we have one atrial contraction for each one atrial ventricular contraction. Yeah. So if we, and very short VA interval. So if we look in this Doppler image, that it's a mitral aorta, so the mitral would be down and the aorta up. You see this biphasic, and then the atria, and then the ventricle. There is one atrial contraction, one ventricular contraction, one atrial contraction, one ventricular contraction. So there is the relation, it's 1 to 1. If we measure the VA interval, we see that it's very, very short. If we look that with the M mode, again, we see here that for each atrial contraction, there is one ventricular contraction. So the relation is 1 to 1, 1 to 1. And we can also measure this VA interval and see that it's very, very short. Okay, another example. This is an atrial flutter. That's something that, an alteration that happens within the atria. So the atria becomes like crazy and it's not really, and it's generating lots and lots and lots of contractions. Sometimes the atrial rhythm can go as fast as 300 or 400, yeah? So in these cases, you will see here in the video that the atria is going so fast that we cannot do it. Luckily, the fetus has the AB node that stops, yeah, because imagine that a heart that is going 500 beats per minute, that would be crazy. So the atrial node can stop some of these crazy atrial contractions, and only some of them will pass. So what we will see typically is the atrial rate is higher, 300, 400, and the ventricular wave rate is smaller. Yeah, because not all the cardiac, all the atrial contractions are sent to the ventricle. So in the Doppler, we see lots of atrial contractions. You see all these small waves here that are atrial contractions that actually they are called AF waves. And then somehow every 4 or 5 is transmitted to the ventricle and we have less ventricular contractions. So if you see differently from the previous, in the previous we had one atrial contraction, one ventricular. In this one, we have lots of atrial contractions and only once in a while ventricular contractions. We can also see the same with M mode. Yeah, that we see down here, the AF waves, a lot of atrial contractions down here, and then only some of them are giving ventricular contractions. Okay, and the last example, we are going to now to see a bradycardia in the AV block. in this AB block, what happens is that something happens to this AB node that it's partially or totally blocked. So the atrial contractions have difficulty to go to the ventricular contractions. This is typical, for example, for immunological patients with the anti-Ro antibodies, for example, doing an inflammation and blocking this part. So in the video, we are seeing a fetal heart that is going very, very slowly. And then this can have different degrees. In this case, the second degree AB block, we have 2 atrial contractions for each B. So it means that one is transmitted and one not. Yes, so we see here, for example, atrial contraction that does nothing, second atrial contraction that transmits to the ventricle. One atrial contraction that transmits nothing, second atrial contraction that is transmitted to the ventricle. So we see that the relation is 2 atrial, 1 ventricle. So we can see that this is an AB block. Some cases, the block is complete. So in this is a third degree AB block, and there is a dissociation between the atria and the ventricle. You see here in M mode that we have some atrial contractions, that usually are regular, and only some of them with no pattern are transmitted. This is a third degree AB block. Okay, again, I know that arrhythmias are very difficult, and I'm not meaning that we need to memorize or remember all of these, but of course, we have lots of books that we can check, or by internet that we can check the typical pattern of each arrhythmia, but the important is to know, first, to check the ventricular heart rate to know if we are at tachycardia, bradycardia, or extrasystole. For this, just do the umbilical artery. That's okay. With this, we know what's going on. But then second, you need to apply or Doppler or M mode to be able to see at the same time the atria and the ventricle. Once you know the relation between the atria and the ventricle, if they are 1-to-1 or 2-to-1 or 5-to-1, and then ideally you can also measure this AB-BA interval, then you will know, okay, imagine that's a tachycardia with the AB relation 1-to-1 and the AB-BA interval is short. Then you can go to the book or the internet and look, and then you will have the name of the tachycardia. Yeah. But it's important because if not, even if you look at it, if you don't know the relation between the A and the B, you are not going to be able to give a surname to this tachycardia or bradycardia, and then to know the treatment. Yeah, so it's very important that you spend time looking first at the umbilical and then spending time on Doppler or M mode to try to clarify which is the AB relation, and with this will be able to give this surname and then know how to manage, how urgent it is, or if it needs treatment. So that was everything from my side. Thank you very much for your attention.
Thank you so much. It was a really wonderful talk, ma'am. And it was really crispy, rather in a very short note. And you have explained in such a nice way in the Monday morning what we can do actually. That is most important thing, ma'am. It was really absolutely very good. And so many questions are putting on, ma'am. Can we ask the questions, ma'am?
Sure. Yes.
Yeah, ma'am. So Dr. Ujma Patel has asked which site to refer for the classification of the arrhythmias.
Sorry?
Which site to refer for the classification of the arrhythmias? Maybe she's asking about the site or any kind of good papers or something like you by use.
Site.
Yeah.
I think that it's mainly books. Yeah, because I don't know a particular good like so papers usually in the literature talk about a specific arrhythmias, but I think it's better to look for books that or protocols. Yes, in Barcelona we have a protocol of arrhythmias that explains very well. It's in Spanish. I'm not sure if we already have it in English. It may happen that I will check it, and if it's in English, I can also share it. It's the protocol from our hospital, but I don't think it's papers. It's or books or protocols from institutions. Yeah.
That's great, ma'am. Ma'am, another questions by Dr. Lakshmi Prashanti. How to differentiate benign arterial ectopics and AB block?
Okay. Okay. So usually atrial ectop. So okay, let me, how to say it? That's a not easy question.
Yeah.
Okay, the AB block, yeah.
Mm.
Sometimes you can like mislead. Sometimes, how to say? Sometimes you need time. Yeah. So sometimes you will need to, because sometimes you look at the baby and then you look at it and then you do and you know the AB relation and everything. It's clear that's it. Sometimes I try to simplify it, but sometimes it's not like this. Or even if it's very clear, sometimes you need to recheck the patient because arrhythmias sometimes change and sometimes they are into the arrhythmia and then sometimes go out. So with the ectopic beats, usually an ectopic beat, it happens as I said. Sometimes it transmits, sometimes it does not transmit. So we can see that stop. But usually what you see is that you have regular and once in a while you have this irregular rhythm that it's the one that not transmitted, but then usually it comes back to normal rhythm. Yeah. It's
Yeah.
true that
That's
sometimes
not
in ectopic beats, it stays a lot like this, but usually the typical thing is that you have an ectopic beat, but then you have normal rhythm.
How many
In
days
an
you take
AB,
the interval to get the normal things? How
yeah,
many
yeah.
days?
No, but usually if you are doing a scan and it lasted 10, 15 minutes, it should come back to normal at some point. With AB block, it will never come back to normal. With AB block, it's always like this, always like this. Yeah. If you are not sure, you can wait some minutes, send the patient to work and then coming back. But with ectopic beats, it comes back to no. At least you have somehow a period of normal. Yeah.
Yeah. So many other questions are there, ma'am. In pregnancies at 39 to 40 weeks of gestation, I often observe fused E and A wave and in tricuspid valve. The same pattern appears on the tissue Doppler as well. Is this technical error or physiological phenomena? Actually, nice
No,
question.
no. It's physiologically. Yeah. So actually, I was, yeah, and think that when the baby goes, does some movements, this is typically turned, but also it can happen earlier, because we are seeing the baby and then sometimes the baby does movements and gets the heart rate increases a bit and then we have this fusion of AB. It's that because usually you have the A and the E, but sometimes when the baby goes fast, it fuses. That's completely normal because then when the baby it's like more quiet, it reduces. Then when I was explaining different ways of tips to use the Doppler, first I tried as I show it the mitral and aorta because it's easy to understand because you have this, but it's true that if the baby, for example, is in a very hard tachycardia, they get fused and then you are lost. That's why it's important to at least know at least two ways of doing it. Yeah.
Thank you, ma'am. Another question, how to, by Dr. Puldeep, how to proceed in case of a first degree heart block? What is the objective criteria of sought VA interval?
The interval. Usually it's the normal values are 14 milliseconds. Below 14, usually we scan them, and if they are below 15 milliseconds, we rescan, but below 14 milliseconds, it's supposed to be like too short.
Too short. Basically, we are calculating the difference between ventricular and atrial coordination. That is the
Yes.
most crux actually we want to diagnose. And another question by Dr. Delcy. When the heart rate is very fast, which Doppler assessment you recommend for the AB measurement? That's a nice question, ma'am.
Yeah. So actually, the most informatives are or the pulmonary artery and vein because they never get fused. You have always there, or the superior vena cava and aorta. Superior vena cava and aorta, it's super nice. However, technically, it's the most difficult because it's not it's a plane that it's weird. But then, what I could recommend is that you have normal babies in your clinic. So one day that you have time, you try to get it, no? Try to get the pulmonary artery and vein, or try to get because when you get used to it, it's actually from a sagittal that you see the aorta and superior vena cava, you put the gate there and you have there. I mean, that's something practical that you need to get training with a normal baby, because then when you have the arrhythmia in front of you, you get nervous and then it's difficult, no?
Ma'am, axial is better or sagittal section is better in superior vena cava?
To me, it's easier the sagittal.
Sagittal. Okay. Another question, ma'am. Everybody has explained in a very nice way. Many people are very much thanking you a lot regarding this. My question is about, ma'am, you are showing a fetal ECG. How much in the era of ultrasound, where we are actually seeing the hemodynamics in a much, much better way in a fetal hemodynamics. So what is the role of fetal ECG actually? In our country, it is not so.
No, no, no,
That's
no,
why
no.
we are thinking that we are actually taking a back seat in the fetal ECG. Is it true?
No, no, because fetal ECG, it's not feasible that at this moment. So we have these magnetocardiograms that they are done in some specific, but that's a huge machine, very complex, that has done that it's can work, but it's mainly used for research. In some, we don't have it in our center, and it's not a clinical standard. It's just a research. I don't know if at some point we will be able to have this fetal ECG. But I have to say that with the ultrasound, with Doppler or with M mode, usually most of the arrhythmias you can know about the diagnosis, and then to treat it properly, it's enough.
Madam, how you're going to prognosticate in case of bradyarrhythmia as well as trachyarrhythmia? If I'm counting down to a severity prognosticators, so which are the severity prognosticators in case of bradyarrhythmia and tachyarrhythmia?
Yeah, so I mean, the important thing is to allow the baby to survive. So it's the eye drops. So if you have a baby that has already ascites or eye drops, it's telling you that no, that the baby is in a severe condition. If it's in any case, the ideal thing is to try to treat the arrhythmias always in utero, always, because then if you deliver a baby with a supraventricular tachycardia hydropic, the prognosis is very bad, because for the neonatologist will be very difficult to manage. You can try to, of course, to give the drugs to the mother, and then to try to treat the arrhythmias as better as possible. And then, yeah.
Ma'am, any role of
eye drops, it's the, yeah.
Any role of hydrocortisone as well as fetal pacemakers intrauterine?
Well, the hydrocortisone for AV block is a very debated thing. Yes, some center, there is not a consensus. The problem is that we don't have a good randomized trial to give the answer. So then, depending on the centers,
Yes.
they are doing like follow-up to diagnose it and to give hydrocortisone. Some papers say it proves, some papers say it doesn't improve. We don't know. We would need a big randomized trial, which is very difficult to do because it's a rare condition, to really know it. So if you are not giving it, it's okay. If you are giving it, it's also okay, because there is no consensus to do that.
Madam, intrauterine pacemakers, which kind of pacemakers you are advising in your centers?
Intrauterine, so prenatal pacemakers, we are not using it.
Oh,
Yeah, it would be postnatal.
okay.
Yeah.
Thank you so much, ma'am. It was a really nice amalgamation of everything. And
Yeah.
can we add the cardiac function, ma'am? In case of arrhythmia, is there any role of cardiac function by HQ studies and all?
Yeah. So
Is
the
there
problem with cardiac function is that it's very difficult to interpret. Yeah. So what happens for example, in a tachycardia is the heart goes so fast that it does not have time to feel. And then it contracts very fast, but the heart has no blood inside because it has no time to fill. So then it can go to heart failure to that. So then trying to measure the typical cardiac function parameters that we are measuring in other conditions, they are very difficult to interpret and not a clear role on clinical management at this point.
So it is the best for the ultrasound, but the ways you have shown, very simplified actually. We are
Yeah, the
kind
Doppler
looking.
and the M mode. Yeah,
Yeah.
because I know that people doesn't like M mode, but M mode, it's super nice when I would recommend you to know or to try in your normal fetus one of the Dopplers that I have said, and the M mode, that it's super easy, just a 45-degree heart, and then slice at the same time the ventricle and the atria, and you will see it. And then in tachycardias, actually it is the easiest, because you see in Doppler sometimes you get fused waves and you don't see it that well. But try normal fetus, and then when you have an arrhythmia, go step by step, the umbilical, and then or the mode or the Doppler, and then once you understand what's the relation between the atria and the ventricle, that's it, you are done.
Thank you so much, ma'am.
Super.
We will be moving towards a nice advertisements by Sonoscape,
Super.
and we are going for a next conference in the next week also. So we want to have a little bit of time for that. Thank you.
Super.
Yeah, we are waiting for your next lecture actually. Yeah.
Looking
Uh,
forward, yes.
over to Mr. Gaurav, Sonoscape, who have been very this academic support, and
Yeah.
he'll be just briefing out Sonoscape's recent innovations in artificial imaging and fetal medicine, and also about the upcoming events.
Yeah.
Over to you, Mr. Gaurav.
Thank you, Dr. Dilepan. Good evening, everybody. I'm Gaurav, this side, marketing head from Sonoscape India. On behalf of Sonoscape, I'd like to thank the organizing team, Dr. Dilepan, Dr. Malti, to give us an opportunity to be a part of this educational event. Thank you, Dr. Fatima, to be on board and giving such a informative lectures on fetal echo. So I'll just take few minutes of all of you to take you through the innovations, what we are doing in our ultrasound products, what we are having in our product portfolio. Okay, a brief introduction about Sonoscape. So we are the manufacturers for the medical equipments, mainly ultrasound systems. So we started our organization in 2002, and 2004 was the first ultrasound system which was manufactured and installed in the market. Then every second year we come up with different kinds of models, different segments of model ultrasound models, which were catering different applications in ultrasound modality. In 2021, our portable X5 was sent to us to Chinese space station, basically for the research work. We have these product portfolios in our organization. So ultrasound systems, endoscopy systems, MIS solutions, and cardiovascular systems, what we are having in our product portfolio. We have multiple branches across the country. In India, we have two offices, one in Delhi, one in Chennai. As I previously told, we have 4 product segments. We have 7 R&D centers globally wherever our R&D engineers do a lot of innovations and development for the new products and the technologies. We have more than 2,000 employees working across globe, and we export our equipments to more than 170 countries and regions globally. So we have currently 30 models in our ultrasound product portfolio. We have 60 probes, transducers, which caters different applications, and all are manufactured in-house. We have our first AI based S-Fetus, which makes the workflow scan for obstetrics much easier. We have a leading edge technology for our transducer, which gives a very good resolution with very good penetration. The hardware of the equipments are totally latest technology, so that the workflow becomes much easier. Because of the strong hardware, our systems can perform AI applications, which makes the ultrasound scans much easier, which I'll be explaining in next few slides. And as I explained, S-Fetus is basically which makes the obstetric scan much easier. So all the equipments are shared service platform, which provides you solutions for a liver solution, for cardiovascular solutions, thyroid and breast solutions, obstetric screening solutions, and gynecology and IVF solutions can be done. Our systems can do all kinds of scans. Now, very important question, what we expect when AI meets ultrasound. So we, as the organization, started working on AI from 2016. And every year we started with machine learning, then we incorporated AI in single images, then into cine loops, and into 3D, 4D. And currently we are doing RF deep learning, which makes a lot of work much easier for ultrasound scans. So coming on to the images, as we have S-thyroid, where it automatically detects the nodules which are there in thyroid just with the click of a button based on AI platform. And it gives all the orientation and the thyroid values also with all the measurements which are required. Same thing for breast. For breast nodules, it identifies the nodules, it takes all the measurements, it gives you the Biret readings just with the click of a button based on AI platform. Coming on to the gynecology, for S-uterus, it takes all the uterus measurements, it takes the endometrial measurements, it takes the endometrial volume, all the measurements, it just takes just with the click of a button, which makes your workflow much easier. Same thing for pelvic floor, it take all the pelvic floor 2D measurements, angle measurements just with the click of a button. hip measurement again, just with the click of a button. Now coming into the cine loops, we has, as I told, S fetus. So as per the ISUOG scanning guidelines for the second and third trimester, it has been incorporated with that so that your second and third trimester scans can be much easier. So what exactly happens if you do manually, for example, a couple of measurements, it takes a lot of time and a lot of keystrokes to do the work done. But with S fetus, just with the click of a button, it takes just 3 seconds and one click it and your work is done. So as a doctor, your main job is to scan and to diagnose what is coming onto the screen. Rest, whatever things which are in between to operate the system, that has been taken care by AI. As I come to the next slide, S fetus. So as you start scanning, you can see on the left side there is a ISOG scanning guideline sections are displayed, and once you start scanning, automatically the machine will start identifying the sections, and it will start tick mark that these sections has already been taken. And there is a quality control bar also, which gives you the accuracy level, by what accuracy level the AI has acquired this specific section. And then if you want to correct that also, if you want to upgrade also, that can also be done within the scan. Like AI in fetal echo. So there are AI in fetal echo where the axis measurements for heart and the transthoracic measurements can be taken just with the click of a button. And then we have stick and stare mode, which makes the scan much easier to make the diagnosis much confident. Coming on to the gynecology, automatic follicle count while you are scanning. If you can see the left side and on the right side of the screen, you can see it measures the measurements also. It is not required that you only need to use a volume probe. With the normal TV probe also, AI works and you can do all these scans very easily. Onto the volumetric, these are normal 3D faces, but we have HD portrait. Recently, we have introduced in our S80 product, which makes a very realistic images. Same way for pelvic floor 3D measurements, you just need to click a AI button and it takes all the measurements in 3D and makes your work scan very easy. Same way, auto pelvic floor, you don't have to do anything. You just opening and closing of the images. Multi-slice imaging for the anal canal takes automatically just with the click of a button. So if you see today, we have bought many applications under the umbrella of AI, which makes the workflow much easier, and you can save your time per scan. So thank you so much for that. I'll not take much time on that. Just one more information on the upcoming event, which we are doing in the month of August. So we are doing a maternofetal concave. It's a hybrid meeting, 23rd and 24th of August. It's a ISOG approved event. We are doing in Tiruchi, in Marriott. So there are multiple workshops, 4 workshops, which are there in this, and there is a noun faculty which will be there to execute this event here. It's a hybrid model which is there, and then I'll just just a second, got stuck up. So yeah, there is a workshop on fetal neurosonography, which is there on 23rd of August. Then again, for IOTA, this maternity convoy is there. There are international faculties also who are joining us online for this event. So you can register through this event very easily. There is an abstract also for the topics for gynec imaging, for neuroimaging, fetal echo, FGR, fetal therapy, and fetal surgery can be paper and poster presentations are there in that. So there are some discounted prices also, which right now are available till 10th of July. So whosoever want to register for this event, kindly you can have a link on the chat box. You can go through that link and then you can register to this event. So that's all from my side. Thank you so much.
Thank you, Gaurav, for the explaining us about the innovations in Sonoscape and about the future events. Over to you, ma'am, Devashmita ma'am, to talk
Yeah.
about the next topic.
Yeah. So just a minute. I would like to welcome Dr. Dilipan regarding the next topic with Fatima ma'am, that is IUGR and the prediction of IUGR in a new way. That is most important thing. What else we are going to see in the evidences of the IUGR prediction actually. That is what. Ma'am,
Okay,
your mic. Yeah, ma'am.
okay. So let me share. Okay. So let's talk about small babies, about the IUGR. Okay, so very briefly, just I guess you all know that the IUGR is commonly defined as those babies that are born below the 10th centile, and it affects about 7 to 10% of all newborns. We have the early IUGR and very severe cases most commonly associated to preeclampsia, and the late IUGR cases. All of them, even if they are early or late, associate more perinatal mortality and complications. They also have learning disabilities and later cardiovascular risk and obesity. So then it's very, very important to early diagnose them and try to management in the optimal way, because then by that we are going to prevent perinatal complications, but also the long-term consequences. So I will be following 3 basic steps for the management of IUGR. First, we are going to talk about how to predict and detect the small fetuses. Second, we are going to talk about how to distinguish between the small for gestational age and the IUGR, so the apparently or more healthy or less risky small for gestational age, or the IUGR or fetal growth restriction babies that are associated to placental insufficiency. And then third, we are going to talk briefly about how to deliver and follow up these babies. Okay, to detect. In order to talk about how to detect the small fetuses, we will need to differentiate between these early onset and late onset cases. Yeah, you know that we have a proportion of babies that are born small earlier, before 32 or 34 weeks. These cases are usually very, very severe, with typically abnormal umbilical and MCA Doppler and CPR altered. And then they are usually associated to preeclampsia. On the contrary, we have the late onset cases that we will discuss later that are less severe but more commonly. So we focus about the early onset cases, and for this, the clue is that many of them will be associated or will share characteristics with preeclampsia. So then, how are we going to detect these early small fetuses? So in first trimester, if you are doing screening for preeclampsia, which I think that most of us are doing already, because we have the evidence that high-risk patients from preeclampsia will benefit from taking aspirin from the ESPE trial. So we should all be doing screening for preeclampsia. So when we are doing this screening for preeclampsia using maternal characteristics, the uterine artery Doppler, the blood pressure, and ideally also the angiogenic factors in the first trimester, we will be detecting patients high risk for preeclampsia, but also high risk for early IUGR, because they are going very much together. Also, in the first trimester scan, it's very important that we use CRL for dating, because dating and a proper dating, we cannot rely on the last menstrual period of patients, even if they know it by heart or they promise whatever. We should always be dating by ultrasound, and by CRL in first trimester is the best way of dating, because then we know how many days we are, and we will be accurate on calculating the estimated fetal weight centile. That's what we need to diagnose an IUGR. And ideally, in the first trimester, we are going to measure the BPD measurement, that we are going to see that we can also use it in second trimester to compare and to see the growth. Yes, so actually, to detect small fetuses, the key point and the most important time point will be the first trimester doing this screening for preeclampsia. the CRL4 dating and measure the BPD. Next, in second trimester, we can re-estimate the risk for small fetus for early IUGR. We will know the patients that are high risk for preeclampsia from the first trimester. So for this, we need to do nothing else. We can also calculate the relative growth from first to second trimester. That in order to do that, we use in a calculator, we compare the BPD in the first trimester and we calculate the relation with the BPD at the 20-week scan. So we can calculate this growth or this difference from the first and second trimester, and for this estimate if it's below 10 centile or not. And on top of that, we could also use a checklist. From example, the Royal College of Obstetrics and Gynecology has a checklist of high-risk factors for IUGR, and this is mainly clinical parameters, and it also includes high risk of preeclampsia. Actually, as I said, the most important would be the first trimester. That will give us really the high risk for preeclampsia. But as I'm saying, in second trimester, you can add this BPD difference, or you can double check the epidemiological risk to then classify the patients in high risk and low risk. This is very important because all these first trimester and second trimester information will tell us which are the patients at high risk of having an early IUGR. And then in these high risk patients, we will schedule an ultrasound at 28 weeks, 32 weeks, and 36 weeks. And in this ultrasound, we are going to check the estimated fetal weight, calculate the estimated fetal weight centile, and if they are below the 10 centile, we will know that we have an early IUGR. The low risk population, we will talk later. Yeah, but all this first trimester saying it's the most important, ideally doing something else in second trimester to select those patients that will benefit with these serial ultrasounds. Okay, then what about the late onset IUGR? These are babies that are born above 32 or 34 weeks. You see here that the proportion of abnormal Doppler is not that much. Many times it happens late in pregnancy, and the challenge here is to diagnose it early in pregnancy, because as I was saying, this usually happens late in pregnancy and they are not that much associated. Usually they are not associated to preeclampsia or much later. So for that, there is evidence that the best approach is to do universal ultrasound. So doing that selective ultrasound that I was proposing for early IUGR will be very good to detect early IUGR, but not for late IUGR, because for late IUGR, we should be doing universal ultrasound in third trimester to all of our patients, because the detection will improve much more. And the ideal is to do this ultrasound late. Yeah, this is a paper that we did in our center comparing which was the better time point. It was a randomized trial, randomizing patients to do the ultrasound, the third trimester ultrasound at 32 or 36. And to detect late ultrasound, it's much, much easier or much sensitive at 36 weeks. So we should do this ultrasound late. And then we should do it cross-sectional, not to use growth velocity, but to do an ultrasound at 36 weeks and then do the estimated fetal weight centile and see if it's below or above the 10 centile. So if we come back to what we were saying before, no, this high-risk pathway to detect early IUGR, in the low-risk pathway, we should do the ultrasound at 36 weeks, because then it's the optimal way to detect late small fetuses. Yeah, in some centers, they are saying, okay, but then we can miss, but for early IUGR, you should classify the patients at risk in the first trimester and then do serial ultrasound because they are high risk. And then with this, we are going to detect the early IUGR. And for the late, we should be doing universal ultrasound late in pregnancy to calculate the estimated fetal weight to detect these late small fetuses. Okay, so if we are doing all these strategies to detect the small fetus, and then we will need to distinguish whether it's a small for gestational age. These babies usually have better outcome, and we can manage more in a safe way in pregnancy, versus the fetal growth restriction. These are these babies with clear placental insufficiency at high risk of stillbirth or pregnancy complications. So distinguishing between these two entities is very important. In order to do that, we are going to have first the estimated fetal weight below 10 centile. That's what gives us the diagnosis of a small fetus. Then we are going to be doing the Doppler to see if or other things. Yeah. So we are going to say that a baby is fetal growth restriction if it has an estimated fetal weight below the 3rd centile, so it's really, really small because these babies are at higher risk, or the CPR, so the ratio between the middle cerebral artery and the umbilical artery is abnormal, or the umbilical artery is very high. Yeah, so you are seeing here in this graph the predictive value for adverse outcome. In any of these, it's important. And there is recent evidence also that you could measure the soluble fluid and placental growth factor ratio in the maternal blood. And if it's also high, it's also saying us that these babies are at high risk of adverse outcomes. So when we have a small baby, that means a baby that's below the 10th centile, we do measure the Doppler or do the angiogenic factors. And with this, we will be able to classify it in a small for gestational age, that means lower risk, or fetal growth restriction, higher risk, it means more follow-up and more close-up, a different management. Because then when we know if it's AGA or IUGR, in the case of IUGR, we'll need to see how severe it is. So we can classify it in stages of severity. Yeah, we know that the Doppler gives us information about how the baby is adapting to the placental insufficiency and how is evolving. So very early when we diagnose it, very far from the delivery. Yeah, it says here 28 days, more or less, even 1 month before we will need to deliver the baby. The placental insufficiency is already measurable by an abnormal umbilical artery Doppler. Then if this fetus advances in the gestation and we leave this fetus adapt, we will see an absent umbilical artery Doppler that is reflecting that there is really hypoxia. Then if things are worsening, the placenta insufficiency, it's more and more severe and the baby is advancing in gestation, it can happen that we can go to a reverse umbilical artery or pulsatile ductus venosus, that it's saying that most likely there is acidosis, or when the baby is very deteriorated, when we have reverse ductus arteriosus, this is telling us that it is likely acidosis, and we will also detect that by computerized ECG. And just very before the baby is about to die, we will have a low score in the biophysical profile or decelerations in the ECGs. So if you look here, really the Doppler allows us to progressively assess how is the baby. And before the baby gets very deteriorated, by measuring the umbilical artery and the ductus venosus mainly are the most helpful parameters, we will be able to follow this baby and see how it's adapting or how it's progressing or how close we are until the baby really is at risk of acidosis or dying. However, computerized ECG or CTG or the biophysical profile are measures of yes, no. I mean, they are normal or abnormal and they deteriorate very late. Yeah. So it's much, much better to follow the pregnancies with Doppler. Of course, we always use the ECG, but you cannot rely only on CTG because it will advise only when the baby is about to die. Yeah. Once we know that we have all this classification with the Doppler, we will be able to say, okay, that's an IUGR, and to give a stage to this IUGR. So if we just have an abnormal umbilical artery, we will say it's a stage 1. If it's absent, will be stage 2. If the umbilical artery is reversed or the ductus venosus is pulsatile, we will say it's a stage 3. Or if we have reversed ductus venosus or anything abnormal, then we will say it's a stage 4. And giving this staging will help us to then see how often we will need to follow up and when will be the best time to deliver. Yeah. So now let's talk. No, we have detected the small fetus. We are being able to say if it's AGA or IUGR, and in the IUGR to give an stage 1, 2, 3, or 4, and then how to manage that, how to follow up this. Okay. So if we start with this small fetus below 10 centile, we have been doing the CPR, uterine artery, estimated fetal weight below 3rd centile, give us and tell us that if it's a UGR or not, or the ratio of soluble fluid placental growth factor can be also used. Then if it's AGA, it means that this is a relatively low risk baby. It can have also complications, but usually the management is good. So we will be following every 2 weeks. We will be scanning this baby every 2 weeks. If it stays like AGA, it means all the Doppler is normal. Then we keep at following this pregnancy until 40 weeks, and then we consult the deliverer. What happens if one of these AGAs has an abnormal Doppler, or if it's directly an IUGR? Then depending on the staging, if we are stage 1, we can follow this pregnancy every week, do an ultrasound every week and deliver at 37 weeks. If it's stage 2, we will need to follow most closely every 2-3 days and then deliver at 34 weeks. At stage 3, we very close follow-up every day and then deliver at 30 weeks. And if it's stage 4, just deliver it. Yeah, we can maybe wait for corticoids, but then deliver it. And we know that most of the babies that are AGA or stage 1 will be late IUGR, and the early IUGR are the ones that most likely will be going through all these stages. But in any case, the management is irrespective of whether it's early or late. We just follow a protocol. We have our own protocol from Barcelona, but you can follow also the protocol of your own institution. The important thing is to have a protocol and to know how often do I need to scan or when I need to deliver. So again, to insist in this, important to have a protocol to follow that and to have a stage-based management, not just to scan and then depending on how it was my last case or then decide, just to really follow a protocol and then be consequently with this protocol. I have put it here, the link to our calculators. We have this protocol and we also have calculators that you put all the information about the gestational age, estimated fetal weight, the Doppler, and then it tells you the stage of the IUGR or if it's AGA, and tells you how often you need to see and when to deliver. So in conclusion, it's very important to use evidence-based screening to detect that. I think that we all should be doing screening for preeclampsia and ideally dating for CRL, that's clear. And then ideally, if you can do some more things, but to do a good screening. And then for management, use a protocol, our protocol from Barcelona or another protocol, but just to follow our protocol and manage. And just a last thought before I finish, that I know that I guess that most of you know, but we in our research group, we are working to prevent IUGR because we worked many years trying to treat IUGR when we have an IUGR baby, how to treat it, but this didn't work. And I really believe that this will not work because once the placental insufficiency is there and the baby is deteriorating, it will be very difficult to change that. But we did this trial trying to promote or to improve the diet of the mothers or to reduce the stress of the mothers using a mindfulness-based stress reduction program. And then with that, we demonstrated that we could prevent at least 30% of the small babies. Yeah. So if we can improve the diet of our mothers, or we can support the health and the well-being of our mothers by reducing the stress. This trial, we were doing that at 20 weeks, but maybe ideally even doing better. We will at least improve the health of our mothers and prevent part of these small babies. And that was everything. Thank you very much.
Thank you, Professor, for enlightening us in FGR and arrhythmias. Both are complicated topics and useful for a routine practice. So we have 2 questions. The first one is whether to use CRL alone or CRL plus BPD to confirm the dates.
No, the dates is CRL. We just need CRL. The BPD, we use it to compare. Then the BPD in first trimester, we don't use it. We keep the information to then compare it to the BPD at 20 weeks, and then you can calculate the difference between them and to estimate the centile. But to date, for dating, it's CRL in first trimester.
And the next question is whether to use AdLock 1, 2, 3, 4, or what are the things measurements you use, because they feel different consensus makes the same baby feel FGR or SGA, and the machine has inbuilt, and the population charts have different things. Which one to follow?
Yeah, that's very difficult question. So to calculate the estimated fetal weight, the traditional HADLOCs works very well. That's okay. And then for the growth, you can use the our growth curves or the Nicolaides ones or the intergrowth or the WHO. That's complex. The ideal scenario would be that each of you could check what of these growth charts works better in your population. Yeah, and to do an study and to check, okay, I have these babies, I will check which is the growth in each of these curves, and then later I see which one has captured the babies with worse outcomes. That would be the ideal, because there is a lot of discussions in all the congresses, or if we need to use customized or non-customized or whatever. The important thing is at the end what works with you, what works in your population. And the ideal would be to have like Indian growth charts that would apply to your population, and then you would better follow that. But this is something that we will need to keep working. Yeah.
Next question.
Mm.
What role does aortic isthmus Doppler play?
Yeah, aortic isthmus we were using in the past in our protocol, but you have seen that I have not commented on it because we take it out. Aortic isthmus, it's very good predictor of neurological outcomes, so it correlates very well with the neurological complications of IUGR. So that's why we include it in our protocol and we use it for several years, but it had several problems. One problem is that it's relatively difficult to get it in a reliable. So in some babies it's okay, but it's much complicated than even ductus arteriosus. So we were not able to get it in all. And then the aortic isthmus also has problems that if, for example, the baby is breathing or the baby is moving, you can get reverse ductus aortic isthmus, and actually it's just because the baby is moving. So it has false positives. And then we estimated all our data, and we saw that if we are using umbilical artery Doppler, middle cerebral artery Doppler, and ductus, with that, we already have a very, very good prediction of the adverse outcome of the babies. And aortic isthmus, adding it, it's not really adding very good and creating lots of problems. That's why we take it out from our protocol.
So can you decide the timing of birth based on CPR?
Well, if you have a baby that it's below the 10th centile, if the CPR is normal, that means umbilical artery is normal, and then it's an AGA, then you don't need to do anything else. However, if you have a baby that is small, the CPR is abnormal, or the estimated fetal weight is below the 3rd centile, or the uterine artery is abnormal, that means that it's an IUGR, then you will need the umbilical artery in the ductus to manage and to deliver. So you will need to do the ductus artery because the parameter that has demonstrated the best correlation with mortality is umbilical artery and ductus venosus. They have randomized trials that have demonstrated that. So it's true that you don't need to do ductus arteriosus if the CPR is normal and the baby is not in the below the 3rd centile. But if it's IUGR, you need the ductus arteriosus.
Okay, and there one case they have said, what about an early FGR, 3rd centile, with gestational hypertension and previous pregnancy with FGR, now at 33 weeks, 5 days, with umbilical artery at 95th centile. The DV is good. Can we take this till term if DV is normal and BP is controlled?
Yes. So the important thing of these cases is to follow the protocol. So if it's 30 weeks and the umbilical is just pulsatile, but the ductus is normal and the preeclampsia of the mother is controlled, then you can keep on following every week, and then follow when there is a deterioration, then you manage depending on the protocol. Yeah. So many cases the preeclampsia is complicating the IUGR, And what the preeclampsia does is that sometimes if the mother is deteriorated and with very high blood pressure, maybe instead of the cascade of Doppler deterioration goes faster. Yeah, so what we need is to follow and then follow the same protocol, but knowing that with the preeclampsia, it's important to stabilize the preeclampsia and then follow the baby. Yeah. But to follow the protocol in the same way.
Sometimes, in spite of normal umbilical artery and MCA Doppler, you may get abnormal CPR. How to go about it?
No, you take the CPR. Yeah, because that's the nice thing of CPR, that it's more sensitive than umbilical or MCA alone. So you don't look, I mean, when you classify the small baby, you look, okay, I have a baby below the 10th centile. Is the centile below third? Yes or no? Is the CPR normal or abnormal? Yes or no? So you look at the CPR, you don't look at the individual components. So you take the CPR.
Yeah. So do you consider a high-risk group if the weight of the fetus is below 20th centile?
No. It's the 10th centile. Yeah.
Okay,
Yeah.
what to do when the CPR is more than 1, but the centiles are less than 5?
No, you look at the centiles because the CPR it's changing all over the pregnancy, and at the end of the pregnancy lowers down very much. So you always have to use a calculator or to look at the table and to look at the centile always.
Until what weeks the CPR is sensitive, and after, like, how do you do it in your way?
Until 40.
Okay.
Actually, we also use it to manage the post-term pregnancy. So, but you have to look at the centile. I mean, because
Okay.
it's lowering down a lot.
Is there any provision the FGR calculators to incorporate the Indian population database and the other things, or it what is the thing based on the Barcelona calculators? Is it
Yeah.
the
So
European population?
in our population, so in our calculators, our population is a lot of European population. We have a lot of Latin American also, and then a mixture. We have some Indians and some people from Asia, but it's true that the percentage is low. If you use Nicolaides population, it's pretty similar to us, plus that they have more black people than we have, and they have less Latin people. But I don't know, the intergrowth, I think it has more, at least for the growth charts, it has an Indian population there.
Okay.
But yeah, the ideal would be that all the Indians go together and do your own calculators with your own population. In the meantime, you will need to use another one.
Okay,
Mostly
ma'am.
Doppler, it's not that different. I think it's very different for the growth.
Mm.
Growth is different. But for the Doppler, I think because the whatever, I mean, in most of the studies, the values vary a bit, but not that much.
Okay. And Debashmita ma'am, are you there, ma'am? Can you just ask any questions?
Yeah. Actually, ma'am, it was a really nice session. In our country, many cases are not in a queue of follow-up. Like you are telling first trimester, you are doing the CRL, then you are dating the pregnancy. After that, you are going for the BPD measurement and HC at 20th week. And you are calculating to that parameter, then you are calculating all the centiles and everything. That is the best way out. But in our country, the people may come to us at around 24 weeks, all of a sudden. So in that case, how you're going to correlate a early IUGR in those kind of cases actually?
Yeah, and then you have to date at with BPD at 20 weeks or 28 weeks. The first scan that you have, then you date by the BPD. That's the best.
That's
The-
the best.
yeah.
Yeah.
That's
But
not optimal, but that's the best.
And uterine artery PI and all that, whatever it will
Well,
be.
you can also do the uterine artery PI to predict so you could do like the estimated fetal, the estimated fetal weight at 28 weeks, 24 weeks, you can do it. Then to do the BPD, and then you can do the uterine artery, yes, to select those high risk pregnancies. But then it's a pity because then you miss the opportunity to give the aspirin early, no?
Yeah, that's true,
Then
ma'am.
it's something that because okay, to diagnose the IUGR, maybe even if you diagnose it late, maybe okay, You can more or less manage. But the aspirin, you have to give it early before 16 weeks. So that's really a pity because it changes. We have seen it in our institution that now we have much more early IUGR. We used to have a lot, and we have now much less and preeclampsias because we are doing this screening. And with the aspirin,
Yeah,
you
ma'am.
prevent some of them or you delay some of them. So it
Yeah.
has changed a lot. And that's something serious to think about and to try to improve, to do this first trimester for
Yeah.
screening preeclampsia. Yeah.
And ma'am, another question: what are the placental predictors, placental morphology? What we are seeing through ultrasound, are they are going to help in the IUGR predictions and all?
Yeah. I
Or
think
we
that
have to worry as
yeah.
should we take it as a parameter for the high risk group?
At this point, no, they are still all in research. I'm not sure if we are going to incorporate them because umbilical artery is very good. And the ductus venosus also is very good predictor. So yeah.
Hyperplacentosis doesn't mark for always for the IUGR. It can be
No.
for everything. Yeah.
It's true that some cases of IUGR, you see that the placenta is weird and then
Yeah.
there should be something there. I don't know, maybe with artificial intelligence in the future, we will be able to measure this weird placenta or the thicker or that sometimes has hematomas or sometimes has strange things. But at this point, we are not using for clinical management.
Yeah. So, ma'am, are you going to predict about the kidneys of IUGR babies, kidneys, liver? Are you going to go for those morphologies while we are seeing IUGR in a grade 3 or grade 4? We are seeing in early IUGR.
What we do is to do like a good
Heart,
anatomical to check
remodeling
that there is
heart.
nothing, an anomaly, because sometimes these small babies, let's say it from the other side, genetic disorders that can give anomalies very typically also give small babies. So many times when you diagnose a small baby, there is, I don't know, another anomaly, a congenital heart disease or a brain anomaly or kidney anomaly, whatever. So it's very important. I didn't say it, but that's true. It's very important that first you check all the anatomy. And if needed, you also check the genetics. So usually we check for genetics when the baby is very small, below third centile, or if there is anything else. No, for example, imagine that you have some accumulation in the kidney, or you see, I don't know, you see anything else, we also go for genetics. Yeah, that's very important.
Genetics is also a part of thing.
Yes, in the very small
Actually
babies.
great. And we are waiting for the next predators from your lab and your institution. We are waiting for that. Thank you, ma'am. It's all great sessions. And
Ma'am,
what
can you please share the upcoming
yeah,
event?
yeah. I'm sharing the upcoming event.
Okay.
Yeah. Ma'am.
Yeah.
Yeah, this is our upcoming event.
Okay.
It's going to be held on, ma'am, on 12th, 13th July. It is a virtual conference actually, and we are concentrating on the fetal heart as well as the fetal brain. So this is our favorite topic actually, and it has been conducted by all Vida Institution by Dr. Dilipan and Dr. Malati from Trichy Medical Center, Fetal Medicine Center, and from our Fetomania Foundation for the Fetomaternal Health. And we are having international faculties on the board from Lubin, Poland, Dr. Magda, Dr. Alexandra, and Professor Yaron Jalal, Professor Karina Hatras from Israel. She will be speaking on the holoprosencephalus and many other hydrocephalus and many other things, neurogenetics as well. And Professor Dr. Marcin will be talking about left hand anomalies and TAPVC, many other things. And Professor Mauricio Herrera will be concentrating on the spinal first trimester to third trimester, how the spine looks and morphology, how it is going to affect in the open neural tip defects and fetal therapy as well. And we have got many kind of national faculties as well. So it is going to be held on 12th to 13th July. I welcome everyone to be there. It will be really a blessing for us. And in future projects also, we want to be associated with you.
Yeah, I'm sorry because Dilepan also invited me to
Dr. Dilipan is there. Yeah.
promote before, but it was impossible for me to attend.
Mhm.
But for sure, yeah, I have never been in India, so I must.
Yeah. Yeah.
So let's see if I can come in person at some point to teach.
Yeah. Mhm.
And
Yes.
Definitely, ma'am. That will be very
Really
useful for the
great.
Indian
Yeah.
students.
Yeah.
Let's,
yeah,
you
well,
can-
I will talk to Edward Gatacos, and then let's see if in our upcoming postgraduate courses I can be there. I would be delighted to come to
Yeah,
India.
ma'am. Yeah, ma'am. In person, learning from you will be great.
Always better. Yes.
Yeah, always better it is. Yeah.
thanks all the participants. We had almost 849 registrations for today's event on a Sunday evening. Thanks everyone for sparing their time, and thanks, ma'am, all the way from Barcelona to dedicate your time for this webinar to enlighten the students here. We are grateful for it and looking forward to much events and welcome you to India uh, to experience the cultural
Yeah.
heritage in India.
Yeah.
Thanks a lot, ma'am. Thanks,
Same.
ma'am, Debashmita, ma'am.
Thank
Thanks.
you. Thank you,
Thanks.
Dilip.
Thanks,
Thank you.
participants. Thanks.
Thank you. Thank you, participants. Yeah. Thank you so much.
Mm.